Thank you, Walter. And thank you for having me, everybody, and James and everyone for inviting me and choosing me over Pedro Ramirez. That's the alternative, I guess, nowadays. Pedro and I are good friends, so that's all right. Somebody tweet this. All right, so I have two talks today, and I apologize. I won't be out, as Walter mentioned, it is my anniversary, so I'll be leaving this afternoon, and I won't be able to stay with you for the rest of the meeting, and I wish I could and be there for the evening, but I do have to get back. All right, so first, this is kind of, these are my views on the robotic platform, which really isn't a robot. It really should be considered computer-assisted technology. It does nothing automatic. It's not really the right term for this platform, and I think that's what created a lot of the problems so far, is thinking that this is something different, and it's some kind of surgery. It's really just a tool to do minimally invasive surgery. That's all it is. These are my disclosures. The U.S. is a big deal, I guess, here too. This is from the open payment system. You can look us all up in the U.S., how much we actually made. I got a whopping total of $1,000 from Intuitive in 2017. So if you think that influences me, there you go. So I have the perspective of doing all approaches in surgery. So I'm not someone who just learned robotics and nothing else. I do big open debulkings and big open surgeries, as well as I trained in laparoscopy without the robot. I picked up the robot after my fellowship. I don't know why my co-fellow, this is us doing a pig lab years ago. That's an endo-stitch device for those of you who still do laparoscopy. I don't know if you use that anymore. I don't know why I'm happy and he's really looking pissed, but I probably cracked a joke on his behalf and he didn't like it. So anyone in this room knows that, at least for endometrial cancer, I'll talk about cervix cancer in the other talk, so we'll stay away from that topic right now, but at least in endometrial cancer, minimally invasive surgery is the standard approach. I mean, that's pretty much it. There's two large randomized trials, which we all know, the GOG Lab 2 as well as LACE, both confirm that there's better outcomes, perioperative outcomes, but also survival. That is two survival curves. They're superimposed. This is from Lab 2, the LACE study. Survival curves, exactly same message. So MIS is the standard for endometrial cancer at least, but the reality is that the tools we have given, this is, we have to be careful how we speak too. I'm not a better surgeon just because I use a robot. It's just that it's the tools I got are better. That's it. And so as folks who don't use the robot, the tools you're given there's limitations. We'll have to admit that. So because of that, in the U.S., as of 2005, less than 10% of women underwent MIS for endometrial cancer. It got better, and in 2010, it was almost 50%, but it's still only 50%, and this also coincides with the introduction of the robotic platform in the U.S. This database, which is from the American College of Surgeons NISQIP database, I think everyone's familiar with that, it doesn't break it out by robot or not, so it just happens to coincide with the introduction of the robotic platform that the MIS cases went up. And this confirms what the randomized trials confirmed. This is more real-world data, which there's some value to that. It's retrospective, but there is value to retrospective data if done correctly. And again, you can see the overall rate of complications is a third of that compared to open. So in a real-world setting, confirming the randomized trials. And they modeled this, that the higher the percentage of MIS done for endometrial cancer, the lower the rate of total complications in the country, as well as the lower the number of hospital days. I've not seen anybody go home the same day after laparotomy yet, but they go home the same day routinely now after our MIS, robotic and laparoscopic cases. It's routine now for us to send patients home the same day of the surgery. And what they actually modeled is that if MIS was done in 90% of cases in the US, there'd be 8,000 fewer complications. You can see the number of less hospital days and $500,000 just for one disease. So when you talk about costs, you have to put this in perspective and not compare robot to laparoscopy, because it's all laparoscopy, and that makes no sense. Really, the way you should be looking at it is how does the introduction of a robot improve your MIS rates? And then you have a cost savings and actually a cost benefit by buying a robot. Now, if you start off saying that you do 90% of your MIS, endometrium MIS, which in the audience everyone always says they do, when they actually look at their data, that's not the case. But be it as it may, if you're doing 90% MIS for endometrium, you don't need a robot. You're already doing something great for your patients, right? Unfortunately, that's not the reality in most hands. And this is true for other things. I run the whole program for MIS for the Department of Surgery at Sloan Kettering, so we look at just more than GYN. And even if you look at other procedures, appendectomy, colectomy, lung lobectomy, the more MIS, the more cost savings. Okay, and keep in mind, you get a robot not just for gynae or for just to do a hysterectomy. Robots are brought into a hospital for a whole program. And once it's there, it's there. And every time you use it, you're not incurring more cost every time you use it, to be honest with you. You're actually decreasing costs, and I'll show you how. And for colon, they weren't any better than we were in GYN. For cancer, colon cancer, in 2007, 7% had MIS colectomies with standard instrumentation. Again, same message looking at the colon, and since we have time constraints, I'll move past this. So our goal is to maximize MIS, minimize laparotomy. Us and 3 other NCCN centers in the U.S. recently published that we think that at least a 80% MIS rate should be the benchmark for most gynecologic oncology programs, irrespective of age, size, or conditions. So all comers, this should be what your goal should be to do in your patients is perform minimally invasive surgery on at least 80% of women with endometrial cancer. So the robots are an evolution of technology. I could watch the Yankees beat the Blue Jays on this TV. I can watch it in color, but I got this at home, you know, just to watch a ball game. But to operate on humans, and this is the 4K. You know how much this cost when this TV came out? It was 20 grand for a TV. So this is what I have at home on a nice comfy couch, but this is what we do for MIS. Operating on humans. It's one of the most complex tasks we have. We take it for granted. We have robotics in space, and oh, that's so fancy, right? But we're operating on humans. You have to think, this is a complex task. You have someone's life in your hands when you're operating. Why not have the best tools that we could have? And computers are all around us. I used to ask who has an iPhone. Now I ask who does not have an iPhone or a Samsung phone in there on them. Yeah, exactly. What do you need that for? It makes your life better, right? That's it. Pilots. Everyone wants to compare surgery and robotics to the airline and into the military. You don't think that a pilot that flew this thing in the 1940s would love to fly this thing now if he was still alive? I mean, give me a break. And this is to kill people. Last I checked, that's its sole purpose. The guy that invented flying, I'm sure he would love to fly one of these new fighter pilots. I mean, think about it. Technology is a given in our lives, but not in surgery. We still fight it in surgery. I don't know why. So the way we see it is that it's really a natural evolution of minimally invasive surgery. And if you truly are a fan of minimally invasive surgery, to be anti-robot makes no sense to me. So we used to look down the scope. I still remember a resident doing tubules that way with the 2-headed scope, and you put the float rings on, no video. There was never a randomized trial looking at video-assisted versus non-video-assisted laparoscopy that I know of. Was there? It's definitely more expensive to buy video cameras. So we went to this, and now this is it. Now we sit down. This is an old picture already. It's not anti-laparoscopy. This is all laparoscopy we're talking about. We at our place have 9 XI robots now. I'm not going to give you the whole history. This is our MI rate. We're just a cancer center. We are not a general hospital. So as mentioned, this week we'll hit 20,000 robotic cases across all services. The vast increase in MIS was directly correlated to the introduction of the robotic platforms in 2006. 2007 actually is when I came back to build it. In colorectal, the MIS rate has doubled because of the introduction of robotics, and there was laparoscopically trained colorectal surgeons on that service. In GYN, same message. In GU, forget about it. Everyone knows the GU story. So you're going to have a robot there for your urologist anyway. Why not take advantage of it? It does not increase operative times once you've learned it. So this is our early experience. We published this 7 years ago. This is our first 3 years of introduction of the robot, 2007, 2010. It took longer. After the first 20 cases per surgeon, which we trained everybody, they were all newly robot trained, all laparoscopic trained surgeons. You know, the times went down significantly. After 40, it went down more. And then after 40, it plateaued and actually equaled the same amount of time to the same type of procedure that was being done with standard laparoscopy. That's it. And this is 7 years ago now that we published it. It's almost 10-year-old data that we looked at. I can tell you now that it's not 180 minutes for us to do a hyst and node dissection with the robot anymore. We're actually going to update all this with more current times and outcomes. It does not increase complications. This is the early introduction of the robot into a big center like ours. Actually, the rate of complications was slightly lower with the robotic platform compared to laparoscopy, but we don't make a point of that because it's all laparoscopy. We don't want to not let people do laparoscopy without the robot, because if you can do it well, then do it. And this is the papers that everyone knows about that talked about costs, but what was in there also is that the complication rates were exactly the same between robotic and laparoscopy. So the robot does not increase complications. That's the dumbest thing I've heard being said. And both of these are much lower than laparotomy. Now here's the costly robot problem. These are Jason Wright famous papers in Rosero and all that stuff. One for endometrial cancer, one benign. So here's the, at worst, difference if you use the robot compared to laparoscopy. Now keep in mind, this is early papers. This is comparing the early introduction of robotics, which took longer for everybody to do. People were using a lot more instruments than we do now, to laparoscopy that had been done for years. That's an unfair comparison. all right? It didn't talk anything about how many open cases were being done in the same cohorts. And so at worst, back then, it was $1,600 more, okay? That's what we're quibbling about, at most, worst case scenario for endometrial cancer, as surgeons. So that's it, forget it. Let's stop improving technology. There's a cost to improving technology. I guess we're done. We're going to do open, standard laparoscopy for the next 1,000 years in surgery, I guess. That's it. That makes no sense. So what didn't get covered in the New York Times, like the other ones did, is that after simply 50 cases total, which I can tell you at our place we've done way more than 50, a little more than 50 cases for endometrium. The difference in cost went down tremendously with increasing experience. The difference now at most is $900 back then, if you agree with it. If you've done 50 cases, what if you've done 5,000? And then the capital cost everybody talks about, that's a moving target. If you buy something for $1 million and use one case, that's $1 million case. You do 1 million cases, that's $1 a case extra, right? And so that we saw in our own institution early on, that as the years went on, the more volume we did, the capital amortized costs will decrease because you use it more often. It's just like buying a plane. The more you fly the thing, the more cost efficient it is. You don't buy it and let it sit there. And platforms are not acquired just for you or your program. They're acquired for a hospital, for other surgeons. And this is Walter's paper that was the friend Susie, the first author there. That is what kind of speared me to look at our own data this way. And this is the right way to look at it, to be honest with you. Before introduction of a robot, and Walter, correct me if I misrepresent here, their rate of MIS was 17%. That sounds, oh, he sucks, right? No, that's the same rate that it was in the US by expert gynecologists who gynecology trained. Actually better than what it was in the US back then. All right, so that doesn't suck. That's just the reality of what it is in most places. You introduced a robot, 98% of his cases now are done MIS. He apparently had a robot donated. He didn't have to actually buy it, but if he had, he still would, because of the change in MIS rates going so high and complications going down, let's say it's going down, they actually save money in treating women with endometrial cancer. Is that about right? So we looked at the same thing with our data because of what I saw with Walter's data. This is over 3,000 endometrial cancers done at MSK from 1993 when we were doing laparoscopy in the 90s, so we had many years of experience with laparoscopy. I mean, you don't need a stats degree to see that laparotomy curve, which is the top one, in the first few years of introducing the robot, what the rate of laparotomy went down to. And if you include the cost of the robot, all 5 that we had at that time, the only increase in cost would have been $500 more. But you're not paying that money every time you use it. The capital's already been spent. So that's not a cost you're incurring, really. And the more you use it, it actually decreases that overall cost. If you actually get rid of that, you're actually saving money by using the robot more. The non-amortized cost difference is actually lower for the whole cohort of patients now because our MIS rates went from 20% up to 80%. And that's how you look at costs. And it's the same thing that Walter had seen, which stimulated us to look at our data this way. In the US, maybe Canadians are much fit. I haven't seen too many of these shaped people in Canada, but in the US, it's a common thing, McDonald syndrome. We looked at the same thing. These are patients with a BMI over 40. We rarely did laparoscopic procedures on these cases. We did paniculectomies and other things. We introduced a robot. The first few years, you see the rate of laparotomy, how tremendously down it went. Even if you include the cost of the robot, we're saving $7,000 per patient. And why is that? Non-amortized $9,000 per patient now, because complications went from 36% down to 15%. Length of stay went from 3 to 4 days down to 0 to 1 day. Every day in the hospital in the US is a minimum of $1,000. Mayo Clinic, so it's not just us. The Mayo Clinic, same message. Another big center in the US. The laparotomy rate's 79%. They introduced a robot, they see Walter's stuff, they see my stuff. Guess what? Laparotomy rates went down to 34% by introduction of the robot into their program. Cheaper to use the robot than to do it open. That's it. Danish study. The Danish have a great, I don't know what Canada's is like, but the Danish, it's like a law that every patient gets enrolled in these registries, especially for cancer. So they capture every single person in Denmark. So it's not a randomized trial, which is a selection, a process, and all that stuff. They looked at the time period before the robot was introduced versus afterwards. This is almost the same curve that I just showed you, just smoothed out better. This is the same, looks the same exact as my curve that I just showed you at our institution. Okay? They introduced a robot. They're already doing laparoscopy. You can see the rate of abdominal hysterectomies, how tremendously down it went by simply the introduction of the robot into the Danish health system. And that's my curve on the right. Now, mine's not as smooth, But it's the same kind of principle, right? And complication rates overall in that second time period where the robot was used went down. That's how you look at introduction to a robot. And if we all could do MIS 90% of the time with the tools we have for standard laparoscopy, that'd be awesome, but we can't. Some can. I know there's people in the audience who always stare at me, oh, I can do it. You just suck. Well, I do. So I got a tool that makes me better. What do you want me to tell you? Rad hist, one slide on here for now. It's cheaper than laparoscopy doing robotic rad hist. If you're doing any MIs. Now, we have to stop shooting ourselves in the foot as surgeons. You know how many people we cure with endometrial cancer just with surgery alone? All the adjuvant treatments, they're improving maybe 2%. We quibble about $900. If you believe that. I don't agree with that, but that's if to say you believe that. We quibble about $900. Look at the cost per everything else that we do with questionable benefit in our cancer patients. That's the monthly cost. The robot is a one-time cost, if you believe that that's the increased cost. So we have to stop shooting ourselves in the foot. We really do. So really, the robot is really computer-assisted surgery. The goal is to maximize MIS rates, whatever way you do that. And guess what? There's a lot of new robotic platforms coming out. I can't say because I have agreements signed. I've met with Verb. I've met with Medtronic. A few other things. It's coming. It's going to be the way of surgery in the future. Us old guys, we're going to be left behind if we don't pick this up. It's just ridiculous. 20 years from now, surgeons will be like, how did you operate without this thing? The incorporation of robot greatly, let me go back here. Did I miss something? It's just a tool, like I said. So incorporating a robot in most centers, I mean, if you're a great laparoscopic surgeon, that's awesome. More power to you. Keep doing it. Don't stop doing it. Don't force yourself to learn a robot if you really feel you've maximized your MIS rates, honestly. But if you do get on the robot, you're going to love it. You'll never go back. It's just the best way to operate. I mean, I'm telling you, it is the best way to operate. To sit down, there's nothing shaking. You control everything. You see better. Why wouldn't you want that? Why do you still want to look at a screen 20 feet away that's 2D and stand up for 12 hours in a day? Why? Tell me why. It's the cost, that's it? Just the cost? Okay. I can show you how that's not the issue. The more you do, also, I love this, the robot's only good for tough cases. Well, that statement in and of itself tells me that there's something better about the robot. Well, we only use it for our tough cases. Well, you're telling me that means it's a better tool then, right? I mean, what the hell? And you're not going to do those tough cases if that's the only cases you do. Those will always be tough cases and challenging. You know, just like any other athlete, any ball player, you practice. You know, you take the easy pitches at you to get better for the game. So you do your simpler stuff. You do more of it. The more you do, the better you get. That's it. That's just the reality. There's no way around that. Doing something once a month is never going to be good. That's a whole other discussion. The more you do, the better you get. The more you reduce costs. You become more cost efficient, more cost conscious. I don't need to use all 4 arms anymore. I can do a simple, straightforward hist with three arms. That's it. Done. There's no ligatures, nothing involved, no vessel sealer. A simple, straightforward hist for hyperplasia, 3 trocars, that could be done. Now, I train fellows. It's painful to train them with just 3 arms, so I tend to go with the 4 or 5 still, and I use that excuse. But I've done it with three arms, and it could be done. In order to do complex cases, which is really why I'm most excited, some of the complex exents and debulkings and some of these things that we do, splenectomies, bowel resections, you're not just going to show up one day and be able to do that if you haven't used the robot to do all the easier things and practiced. So this is one of the most dangerous phrases in the world, I think. We've always done it this way. If someone tells you I've been doing this for 20 years, you should say, well, don't you think it's about time to change? I mean, there's been some new stuff come out recently. So I think this is one of the most dangerous things. This is actually a saying from one of the naval commanders in the U.S. It's time, I mean, when are we going to wake up and embrace the future? I mean, where's the slide? Where's the overhead carousel for doing our talks? You know, all this electronics here. I mean, we have more electronics doing a presentation about robotics than you have in surgery with laparoscopy. So that's the way you need to see this. And the youngsters here, they'll be like, how did you not use this before? So this is the way I've seen the robot. You know, I say some outlandish stuff to keep everybody interested, but I think it is the way we've seen it. MSKCC doesn't like to lose money. You know, we went from 1 standard robot to now 9 XIs and in between a bunch of SIs. So we don't like to lose money. So there's a value to this. Because of the robot and the increase in MIS rates at our institution, we were able to build the Josie Robertson Surgical Center, which is a 23-hour center. All of our prostates now are done there. Our kidneys are done there. That's opened up all the bed space, saved us a ton of money. People going home same day or next day after nephrectomy, prostatectomy, and all the GYN stuff there. But if we weren't able to do that as high a rate of MIS as we did, we would never would have been able to build that center. And that's the way of the future in surgery. Thank you all. I hope this was helpful and on time and time for questions.
Wow. That sure was on time, and I don't think there is any question anymore. I think everything has been said. Anyway, Jim.
Yeah, thank you. Is this on? Thank you for that very illuminating talk. We talk about short-term complications. Is there any data out there about the sort of long-term hernia rates and the long-term complications of laparotomy versus laparoscopy? Because, I mean, the societal costs for bringing somebody back after that big patient you've got there who gets a hernia 40% of the time, 50% of the time, and has a repair, and it takes this general surgeon 8 hours to do that under laparoscopy is huge.
Yeah, and that's a good point. I bring that up. That also, nobody factors that into the cost analysis either that have been done. Sort of the long-term adhesive bowel issues that result from laparotomy, as well as the hernias. So there has not been, as I know, direct comparison. We have published on hernia rates for MIS, for endometrial cancer, and that's at about 1–2%. Yeah. Of which only less than half actually have to be repaired because of cosmetic or it hurts or something like that. And those are usually easy repairs with a little patch done in, I do them in an hour. With laparotomy, we've published for ovary cancer, we had about almost a 30% rate of hernia within 2 years within the laparotomy incision. So we have not looked at it for endometrial cancer, to be honest with you, at our place. But that's our numbers here. So yeah, so after laparotomy, it's anywhere from 20 to 30% rate of hernia, of which more than half of those need to be repaired. And then for MIS, for at least for us, for endometrium, which applies to hysterectomy, I mean, it's not much more than a hysterectomy, it's about 1.5% of what we saw in our data. So it's a much smaller rate of hernia. But nobody really looks at that. Nobody figures out, or has looked at adding the cost of managing those things down the road. And those are costly. Those are costly interventions. What then can lead to additional complications from hernia repair, right? Putting mesh and injury during surgery. So none of that's been factored in any of the costs that have been mentioned, ever.
Thank you, Mario. Besides the technical aspects of comparing laparoscopy to robotics, what's coming in terms of the computer added value? Yeah, in terms of, you have an interface like the iPhone, and some people are very good laparoscopists. They say, well, why do I need to do that? So you have to have some added value, whether it be in terms of different technology that's now added to your field. Yeah. What's coming out? Yeah,
it's a great point. And some of the stuff I can't say too much about, but yeah, that's really our most excitedness, is really how we're going to make it more of an iPhone, really more interactive interface. And, you know, we actually tried to do, the easiest thing is doing overlay of pre-op imaging when you're operating, things like that. I mean, you have Tile Pro now, which you can see the image on the bottom. But even overlaying, there's a lot of technical things with that where, you know, the pre-op scan, which as you operate, that changes. And so you have to do intraop registration and things like that. So that's one aspect. The newer companies coming out, especially with Google being involved with the Verb project, there's a very Apple-like feel or Samsung-type feel, Google-type feel to the console they're creating, where you can do all kinds of things that you thought you might not be able to do while you're operating. Can't say much more than that, but that is really where it's heading, is really now taking advantage of the computer to do just more than just a surgery, but to integrate more into your surgery, such as pre-op scans, overlaying of images, all kinds of things. Conferencing with another surgeon while you're operating, all kinds of things are coming out. And really kind of an app-based interface almost in the console. It's just a matter, I mean, if we really stick with this, who knows what the future holds. Even things we can't think of now might be possible in the future, but it ain't going to be possible without it, with standard laparoscopy instruments at least. You know, without a computer in there somewhere, it's not going to be possible to do some of these fancy things we're thinking about doing. You can imagine automated features. That's being thought of also right now. You can have where if you're training people, you can outline the anatomy and the instruments won't go there. It'll be fixed in a space. And those are actually not that hard to do yet, just they're not in there. But those are the things that are there's a lot of things being developed. And we're behind the times in robotics. I mean, if you look at space robotics and other industry robotics, we're like babies in robotics right now in terms of medical robotics. Yeah, but Marcus.
Hey, Mar. So you mentioned it a little bit in the talk around NISQIP data, and you talked about more than 50 cases. And I just wonder if you have any experience or if you guys have looked at some of the data as we are starting to report more on outcomes more than ever before, I would say, in medicine. I think what we're finding is people that do more of a certain case, have a greater experience with it, are going to have better outcomes. And just in your experience, if you have any of that data from not specifically your center, like one surgeon to another, but just in terms of this concept that, you know, maybe all things shouldn't be distributed equally among all staff, but maybe expertise based on higher number of cases, et cetera.
Yeah, I mean, that doesn't apply. That's not just robotic specific, that comment. That applies to all surgery and anything we do in surgery. There's tons of publications on the higher volume centers, higher volume surgeons having better outcomes. I mean, that's a known, well-published. It just makes sense. You really need a paper to say that the more you do, the better you get at it. In what field that's a physical field is that not the case, right? Occasionally you have some fluke savant who can do one case and be a superstar, I guess, but that's not generally the situation. And even as we get older and we do more and more, you realize that you feel more comfortable doing certain things than when you first started, and you thought then you were a superstar, right? At least that's the way I did. So you know, I think that's the truth is in the matter is that the more you do, the better you get. And like the Danish and other centers, other countries have actually centralized all of their cancer care into only a few centers, and their outcomes are better than the community, quote-unquote, centers. In the U.S., it's a challenge because there's a lot of different types of hospitals out there, and access to centers is an issue too. In the middle, you know, on the coast, it's no problem. You got, just in Manhattan, we have 10 big centers, you know, and we have 110 G1 oncologists just in Manhattan. But then you go to Montana, you got one for the whole state, you know, if you're lucky, and you have to travel miles and miles. So there's challenges to those things, and centralization has always been shown to improve outcomes in whatever form you look at. I'll show you data in the next talk about sort of even in the U.S. comparing just the dedicated cancer centers to the non-dedicated cancer centers to community centers, and cancer outcomes there too are different. So there's absolute different value to centralization as best as possible, but then there's a lot of challenges to actually implementing those changes. And then when you have a smaller country, Canada's not a small country, but like Denmark or smaller countries like that, it's much easier. It's like saying I could do that in New Jersey or New York, but you know, to apply it to a big country like the U.S. with a lot of different scenarios and settings becomes a big challenge.
So, sorry, just to follow up on that, because I think models, you know, in the province of Ontario, for example, where robots are going to be opened up and sort of distributed, there are different models in sort of looking at that and sort of, yep, just every hospital should have one, and they do, you know, a small number of cases, or maybe it should be really creating programs, as you say, smaller, more defined, with higher experience and better outcomes. I
totally agree, and that, again, that applies to hysterectomy for your general GYN who does one hysterectomy a year. That person shouldn't be doing anything at all, robot or open. So, you know, and it's easier in some scenarios in some countries to do that, but in the U.S., you're then talking about taking away business from hospitals. So it's a near impossibility in the U.S. to say that certain hospitals can't get certain things. Good luck with that one. If you want to come tackle that down in the U.S. for us, feel free to come down and help us out. But, you know, it's just a huge challenge because, you know, healthcare is still a business in the U.S. to some degree, and so to say that only certain hospitals can get certain things is really tricky.
Yep.
But I agree with the concept, and I totally agree.
Yep.
Can you hear me okay?
Yeah.
My question relates to your surgical training programs.
Yeah.
We've seen some really nice curves about how the ability of surgeons improve over time, and our complications rate decrease with the amount of surgery that we're doing. Yeah. I recently was reviewing a really old paper looking at a survey of fellowship directors in the U.S. that felt that their fellows starting a surgical training program weren't ready. So I'd be really interested in your insights with regards to how you're addressing surgical training needs in this environment. Thanks.
Man, I'll be up here all day. Keep asking these questions. So that's a whole other aspect too. How do we train? You know, I just showed you that. We do have a publication on when we introduced the robot and looking at our fellows' outcomes, where they did most of all the case on the console versus not, and complication rates. The learning curve was the same, actually, mirrored the same. So we looked at cases. We track everything. Every case that I do robotically has a data sheet entered into our database, and part of it is the percent of the amount of the case the fellow did. So early on, we looked at, in case that the fellow set 100% on the console, I mean, they basically did the whole case, with us there, of course. The rate of complications was actually lower, And their times was also that same 20 to 40 case curve. It mirrored the faculty. Now, their complication rate is lower, not that they're better, it's just because that just shows our judgment in deciding how much we'll let them do. If it's a complex case, I take over more of the case, right? So it just reflects that we can introduce that. The whole, yeah, the SGO, yeah, I answered that survey also. I think OBGYN training needs to change in the US. I don't know, but I can't speak for any other country, I guess, but it'll never change. This whole OBGYN combined training needs to go away. Surgery now has become complex, a lot of different tools, a lot of different things we need to know. The volume is going down overall. So to train everybody to do obstetrics and GYN surgery and be a surgeon, I think is not the way to do training anymore. You really need to split it. And all the office-based stuff, I don't do any office-based stuff, you know. God help me if I have to do a leap, I hate it. I don't have office hysteroscopy, nor do I want to learn that, right? But there's a role for that. So I think really, at some point, which I may never happen, is that before fellowship, you have to start thinking about changing it into like an obstetrics, women's health, office-based sort of training versus a surgical training. And then GYN surgery should only go to certain people who train in GYN surgery. That's a very, it's a big thing to ask that will probably never happen. And so for our training now, I can go over that. I have a whole training program for our fellows and how we integrate it and how we've built it over the years. And I can go over that individually with you because it'll take me a while. But there is a way to integrate the robotic training and other aspects. It also comes down to your volume. You have to have volume. At our institution, we do lots of surgery. So my fellows finished with 400 or 500 robot cases, about 300 laparoscopic non-robot cases, and another 400 open cases. So, it all comes down to your own volume and your practice that you have. And you can't wring water out of a stone if you don't have, so it depends on a lot of factors.
Mario, we'll take the last question from Jake.
I'm happy to chat with you a little later, too.
Jake, quick. Because,
yeah, I'm glad you sort of brought up the Apple and the iPhone aspect to it because it's really only been Da Vinci and no one else. So it's good to hear that there are other companies that are coming into the landscape. You don't have to tell us about the technology, but can you tell us which one we should invest in? Because I think that'd be helpful. Maybe at the break. Anyway, in Canada, things are different and the economics of the situation are more at play. As an example, in Ontario now we have quality-based funding coming in for hysterectomies. And so you get about $5,000 to do a hysterectomy. And it's tough for a hospital to put out robotic hysterectomies at that rate. And really, we're not sure how it's going to play out, but it looks like it might actually drive open surgery, which is exactly the opposite of what we want. What I'm aware of, we have a robot at our center. Our program isn't a great program. Places that have really, effective programs, like Walters, they're run by the foundation, and they're not funded publicly, and we're in a public model. We're not like the US, we're a for-profit game. So it is different in Canada. I'm not sure how to reconcile it, but I think it's a point that we have to recognize.
Yeah, no, I agree. I mean, and even for the US, I'm at a unique center. I get lots of toys because we're whatever. So, I understand that my experience may not apply everywhere, even in the U.S., but it's just an example of how we integrate it into a big center, which there's a lot of anti-MS sentiment at MSK still, to be honest with you. I can tell you, it's just a matter of how U.S. surgeons really champion some of this stuff and push for some of these things, that it's better tools for you to do your surgery. I mean, I was just in Paris a couple months ago. They bought 9 XIs, the Paris health system, for their 9 public hospitals because they were realizing that they have to decrease their laparotomy rates because there's an overall cost savings by doing that. You reduce your readmissions, you open up bed spaces, you have less complications to deal with. That's all cheaper. So they bought 9 XIs, the government health system in Paris. So I think there's definitely barriers and challenges everywhere, and they're unique in every country. But you can really overcome them if you work together and champion it, if you really feel it's something valuable for you in your practice.